So my name is John Griffiths, diabetes specialist, Counties Manukau, DHB. So there should be quite a few more people logging on. Please participate because it's more fun. There's another one here to think about as well. Just we're comparing emotions briefly. It's all touchy-feely. How do we feel before we see a patient with diabetes? So, I mean, the point of that exercise is just potentially to remind ourselves that when we meet our patients, we may be overcoming negative emotions on both sides of the desk. Okay, let's compare knowledge. So here's a question. A patient with diabetes has been started on metformin, 500 milligrams, 2 tabs BD, is experiencing 4 to 6 loose bowel motions per day. The next step should be to. We'll move fairly quickly. Around about 50% of patients who start metformin will experience GI side effects. And around about 5% of them will need to stop the medication. Okay, we love metformin. We want people to be able to take as much of it as they can that they can tolerate. So the correct answer is, in fact, the one at the bottom there. Moving right along. When prescribing suspension insulin, the most important reminder to the patient is the importance of Okay, so resuspending is so important. The number 10 is to remember. You have to rotate the pen through 180 degrees 10 times to get adequate suspension. It's very rarely done by our patients. So that's a variable that we can do without. The other things are important, but that's the most important. A 36-year-old Tongan woman with a BMI of 36, have you got this one? Is it there? Presents with a capillary blood sugar of 20 in the surgery and no symptoms. Both parents type 2 diabetes. Her A1C is 100. The first action you take is to. This is an interesting question. Does it surprise you? I suppose it's based on the fact that we're trying to reinforce to our patients very early on that this is a disease of lifestyle, and handing a script across at this stage is just probably unfortunate and unnecessary. You'll probably hear about a diet study later on today which diet alone resulted in remission of diabetes. I just think the point here is it's the first action. I think what we're trying to do is help our patients to realize that they've got a disease, a condition, which is extremely modifiable by the actions that they take outside of the realm of medication. I'm not saying that you might not do that as your next step, but this is an opportunity to reinforce something important in a young patient. Next. So if a patient is on metformin and gliclazide at those doses with an HbA1c stable at 110, and they are adherent with their diet and medication, this is probably, I'm telling you that's true. That's the thing we often don't know about the patients that we deal with, but I'm telling you that's true. what is the next best course of action? So an obese 45-year-old man has just taken up a job as a labourer. He takes metformin and glipizide in those doses. He has a recent A1C of 87. He comes to see you with repeated symptoms of sweating and nausea, relieved with a drink of Coke at about 4 p.m. You will. Okay, you guys, thank you for participating. This is good. So the answer here is actually to reduce his glipizide dose. This man is doing something amazing for his diabetes. He's engaging in physical activity, and we don't want to discourage that or make that more difficult for him. Your A1C is always history. It's always telling you about the last month, not about what's happening. The temptation to go around, I think you can be fairly confident that this is hypoglycemia without having to do that. This is one of my favourite trials. Are you seeing this? It's a trial that shows that what we do matters and can make a huge difference. Multifactorial intervention of controlling blood pressure, blood sugar control, and lipids, huge impact in terms of cardiovascular disease and mortality benefit. Stop people from dying. But there were non-pharmacological elements to the trial. Which one wasn't one of those elements? So it's a negative question. The following non-pharmacological interactions were part of the trial except for one thing. Yes, this one here is the correct one. 53-year-old builder with a BMI of 42 presents with a thirst and a capillary glucose of 25. He'd been quenching his thirst with Coca-Cola. His A1C was 100. Father has type 2 diabetes. Diet and exercise as treatment should continue here for how long before medication is considered? Like you, I feel the temptation to get on with things. And partly it's due to our feelings of futility about the likelihood of the efficacy of our diet and exercise advice. But it's a form of clinician inertia, if you like. It's like, only it's not around pharmacy, it's around inertia, around our belief in the benefits of lifestyle interventions. So 3 months is the answer. This is slightly more current. Your patient with type 2 diabetes and proteinuria is on metformin, an ACE inhibitor, acarbose, vildagliptin. That's her blood pressure, A1C of 68. She complains of a swollen tongue and lips. You should. So this is a life-threatening, relatively rare situation of the development of angioedema, which can affect the upper airway, obstruct the upper airway. And the learning point here is that while most of you have picked one agent, in fact, vildagliptin increases the risk of this by a factor of 4. So we may end up seeing more of it. So I'll do one more. Okay, a patient on Penmix 30, 40 units BD, arrives yet again without his book or meter. An unusual circumstance. His weight is stable at 95, his A1C is stable at 80, he is adamant he takes his insulin regularly. I can vouch for him. He works in a physical job on morning shift, eating at smoko lunch and main meal that's 1,800 hours. His fasting blood sugars, he tells you, he does the morning one, it's 10. You've seen him at 4 o'clock, and his capillary glucose, which you've done faithfully, because you find them so useful in your room to do them, and you discover it's 8.7. So one of the problems we have is this inertia around dose adjustment. So sometimes we have to act on less than ideal information, and so we have to make some assumptions sometimes. So the learning point here is that you've got an opportunity to adjust, and the safest thing to do is, in fact, the last one. And it's just making every clinical interaction an opportunity to make some adjustments on the basis of information you've got. Okay, that's all from me. Thank you very much.